When we talk about the dying process, we also need to consider the many different types of terminal conditions that someone may be facing. In other words, what types of diseases or illnesses lead to death, and which of them are most frequently encountered? In the United States, many people die from accidents. Anything from traffic accidents to falls, fires, or drownings, among others. These are one of the leading causes of death at all ages. However, there are also many terminal conditions that people suffer from over an extended period of time. Most deaths in our country are due to conditions that are progressive, meaning they get worse over time. They are chronic, or long-term, and they are terminal, or result in death. Many of the more common ones that we think of are heart disease, cancer, Alzheimer's, and so forth. One thing we don't often consider or think about, in large part due to the discomfort that it causes us for just thinking about it, are childhood deaths. In all actuality, there are just about 1 million children in the U.S. who face a life-threatening condition at any given time. To get a better understanding of what types of terminal diseases American men die from most frequently, we can look at this graph, which is based on current findings. If we start at the bottom, we see that the most common terminal diseases experienced by adult males in the U.S. are heart disease and cancer. These two stand out far above the rest. Next, we see chronic lung diseases, strokes, diabetes, kidney disease, and Alzheimer's as other leading causes of death. We need to know this so that we can not only anticipate what types of conditions our patients will be presenting with, but also so we know what's involved in those treatment plans, how each aspect of the patient's life may be affected, and what the prognosis may be after an extended period of time. If we understand these things, we're better able to provide the holistic care and support our patients' need at the end of their lives. We can see here that the most common terminal conditions for women are very similar. Again, we'll see heart disease as the most deadly, followed very closely by cancer. And then further down the line, we again see strokes, lung disease, Alzheimer's, and diabetes. Many people are surprised to see heart disease as high as it is, but we're hoping that with improved preventative care, screening, and even public health initiatives, that women are becoming more aware of these risks. We've seen some commonalities between terminal diseases affecting adult men and women, but what about children? We don't see all the same issues here, but what we do see is still a high rate of death due to cancer. Leukemia is the most common type of childhood cancer diagnosed, but we also see certain types of brain cancers, bone cancers, skin cancers, or other soft tissue cancers in children. Asthma and diabetes are the next most common causes of death, at least in terms of terminal conditions. Certainly, the top cause of death for all children is accidents. Again, things like a fall, drowning, a car accident, fires, other things that may happen around the house. And unfortunately, we also see child abuse as a cause of death far too often. Let's talk about this for a couple of minutes, though, because most people try to avoid the topic of childhood death, since it's even more emotionally challenging to think about. We don't like to see anyone die necessarily, but there's this notion that children are robbed of their futures and don't ever get a chance to really live their life, whereas older adults would have already had their opportunity to live and experience new things. If a child is given a terminal diagnosis with a poor prognosis, how might the parents feel? What kinds of questions are they now facing? How do they know what to do? These are difficult issues for sure, and we see people trying to help their children the best they are able to. At the same time, they have to look at what is realistic, what their quality of life is, and ask themselves what amount of suffering is acceptable. Clearly, these aren't easy decisions, and we can all probably think of examples, either personally, professionally, or even stories we've seen in the media, where parents are facing these heart-wrenching decisions. How do you know when you've put your child through too much? What if they don't want to continue with treatments anymore? Do they have a choice? Can parents force it? What about the doctors or the courts? These are big ethical issues that have no easy answers. Parents are dealing with all of that, and then at the same time, they're likely being barraged by people's advice, suggestions, and comments. Maybe it's different doctors or health professionals. Maybe it's friends and family. Everyone may be giving them advice, and half the time the parents might not even want it. How do they sort through all of that? How do they politely ask someone to stop telling them what to do? How do they even know what they want to do? It's easy to see how this could be very overwhelming for all involved. As healthcare providers, how can we best support these parents and their child? For starters, we want to provide them with information to help them understand what is happening now, as well as what may happen in the future. The information you provide should be honest, gentle, slow as possible, and realistic, not sugar-coated, trying to protect them from things that are hard to hear. We may have to tell them things multiple times. It doesn't mean they aren't listening or they don't believe us. Their minds are just trying to process so much so fast that they cannot possibly remember everything. It helps to keep a notebook in the room so the parents can write down questions they have or things they want to bring up, and likewise, the healthcare team can write down information for the parents as well. Then there's one place that everyone can go for consistent, up-to-date information. As you're working with the parents and child, you'll also want to be honest with them. Remember, they can't really make an informed decision unless they have all the information and all the options, be they positive or have potentially negative side effects. Depending upon the age of the child, the parents will decide how much information to tell them. You need to follow their lead because they're the parents, not you. If you know that they're struggling, be sure to let them know about resources within your hospital, clinic, or in the greater community. They may want to attend a support group, talk with other families, meet with someone from their church or a chaplain, or just have someone to process through everything with. Help them advocate for their child. Crises tend to be chaotic rather than relaxing, so help speak up for what the family or child are needing and wanting. Finally, allow them time and opportunities to still be the parents. Often they feel like the healthcare team takes over everything, but they are still in charge. They can make decisions about care and also about daily interactions, rules, and expectations for their children, be it the one who's sick or the other children they may have as well. Help them feel like they still have some control over what's going on, even though it's a stressful, overwhelming time. Parents likely have many questions when they have a terminally ill child. Help answer these questions by providing them with information that allows them to better understand what's happening and what options they have available. Maybe it's options for treatment, for pain management, for possible recovery, even for smaller everyday types of decisions that need to be made. Remember that they are doing the best they can. Try to listen, answer, and support them without judging them. None of us know what we'd really do unless we were in that exact same situation. And even then, the situation and the set of family dynamics is always unique. Remember earlier in the semester when we talked about the technological imperative, or this notion that we should do whatever is technologically possible to save a life? Well, this comes up here again with a vengeance. No one wants to feel as though they've given up on a child, and yet most people don't want to have the child suffer a great degree either. In the end, it's important that you let parents know that if treatment is not an option, or the attempts they've made have not been successful, that they are not the cause of it. They are not failures. Dying children don't die because support is withdrawn. They die because of their disease or condition that could not be cured. When this happens and parents are facing this difficult decision of whether to continue doing everything possible or to provide comfort cares, they often feel as though they are really facing a choice between something that's terrible and something that's horrible. There are no easy answers. They need to be reassured that they made the best decisions they could with the information and situation at hand. Let's move beyond childhood terminal illness now and continue our discussion of common terminal conditions that many of your adult patients will face. Substance abuse is an ever-increasing problem in even the smallest, most rural areas of our country, and will be something that you see frequently in rural and urban areas. Let's start with alcohol. Certainly, there are many accidents related to alcohol consumption, and we also see relationships between alcohol and violent crimes. There are also deaths related to acute alcohol poisoning, or even long-term consumption of alcohol, such as cirrhosis of the liver. What about tobacco? Even though we know the harmful effects, smoking is still very common among many age groups. In fact, tobacco-related deaths, either from smoking or chewing tobacco, are the #1 most preventable cause of death. Almost 500,000 people die every year in the U.S. alone from tobacco use, even though many of them may have quit 20 or 30 years before they actually died. Illicit drug use is another form of substance abuse that we need to consider. Again, we see drugs playing a role in violent crimes and situations involving homicide or suicide, but we're also experiencing an epidemic of drug-related fatal overdoses. Misuse of prescription drugs is at an all-time high, and we're seeing an alarming trend in heroin-related deaths. Much of this stems from people being addicted to opioid pain pills, which can then easily lead to a heroin addiction. Methamphetamine has also ravaged communities and families of all sizes across this country, and most recently, we've seen synthetic drugs causing horrible problems as well. Deaths related to bath salts, synthetic marijuana, or other synthetic opioids or psychoactive substances are on the rise. Even if someone doesn't die immediately, say of heart failure or suppressed lung functioning, they may have suffered such internal organ damage that they are left to suffer a long, drawn-out, painful death with limited brain activity. Others under the influence of drugs may be more likely to die by suicide or commit violent crimes that often result in their own death. Finally, let's look at some of the most common terminal conditions of the elderly. Before we look at the main diseases themselves, though, we have to remember that there are some elderly who also struggle with addictions and misuse of substances, be it alcohol, tobacco, or increasingly, the overuse of prescription sedatives and tranquilizers. The most common terminal conditions are listed here on the left-hand column: cardiovascular disease, cancer, COPD or chronic lung conditions, stroke, Alzheimer's disease, and diabetes are very similar to what we saw earlier when looking at terminal diseases for adult males and females, so those all make sense. What we see an increase in as one ages, though, are more deaths from pneumonia, influenza, and falls. While many people may die from the actual event or illness, they may also become injured and then very weak and slowly lose functioning over time. So some deaths are sudden and acute, while others are more long and drawn out. We have a separate lecture on the dying process and what's involved for the patient, as well as suggestions for us as healthcare providers. In this part of lecture, I want to take a slightly different approach, revisiting some earlier concepts, as well as looking at additional concerns and opportunities for those facing a terminal illness. When you first get that terminal diagnosis, what do? Do some people retreat within themselves and isolate? Do others reach out to family or friends? No one ever feels prepared for bad news. Everyone is different. So try not to have expectations about how people should or should not react. People likely feel very overwhelmed and scared, and they don't even know where to start. They have people asking them what to do. Do they want to fight it? Do they want to try to buy some time? To look at comfort cares like palliative care or hospice? Or do they want to do nothing? These are tough decisions that patients and families must make, but they often don't have any way of knowing right away. Thus, our job is to support them as they explore their options. We don't want to give them advice or tell them what to do, but rather we want to listen, comfort, and provide information about what options exist. Then we support them until the end, whenever that may be. Many different types of emotions and thoughts run through someone's mind and body when they find out that they are dying. Sometimes people learn that they are ill or have some type of condition that will eventually result in their death, possibly many years down the road. Others receive news that they have very little time left to live. This impacts how they will react to it, what they want to do before they die, and what may be of most concern to them. Here we see 10 of the most common fears experienced by those who are dying. Pain, isolation, loss of physical strength, cognitive changes, loss of ability to continue their favorite activities, role changes, the possibility of needing institutionalized care, loss of independence and eventually becoming completely dependent upon others. And still some may fear death itself. This list is extensive. It is real and raw. We cannot take away all their fears, but we may be able to help lessen some of them, or help some feel more manageable. Let's talk about pain first, since that's the most feared symptom of dying patients. Many people, especially if they're not yet aware of the different pain management techniques, are very afraid of being in excruciating pain. They realize that pain limits what they're able to do, how they're able to interact with others, or participate in activities that they enjoy. Pain also prevents them from being able to resolve any unfinished business. Fortunately, most pain is controllable. There are a variety of methods the healthcare team can use to try to manage their pain. However, we must recognize that only physical pain can be treated with pain medications. Emotional, social, psychological, and spiritual pain, those have to be dealt with by examining the root of the issues that bring about that type of suffering. Rather than arguing with patients about how much pain they're in or trying to limit their options for treatment, we want to involve our patients in managing their own pain, and we need to believe them as they describe their pain. Everyone's pain tolerance is different, and how they experience it is different. In essence, pain is what the patient says it is. As mentioned a moment ago, there are different types and causes of pain. Some pain comes on quickly and leaves. Other pain is ever present and relentless. Some pain ebbs and flows. Psychological, emotional, or spiritual pain may be caused by past experiences, trauma, broken relationships, guilt, or regrets. The type of pain dictates what types of treatments may be most effective in managing it. Since pain is so individualized, it's hard for healthcare providers to always know what level of pain a patient is experiencing, what might be causing it, and how to best manage it. Compounding this are different religious and cultural beliefs. Indeed, in many cultures, one is expected to endure the pain and suffering as a way to make up for past discretions, or to earn their way into the afterlife. Some believe life on earth is the suffering that paves the way for eternal peace and happiness. Thus, people will not only respond differently to pain, but they may also have different preferences about how to handle it. Some wish to do nothing. Others wish for light pain medications, while still others prefer much more aggressive treatment and pain management techniques. There isn't a right or wrong. We also need to look at this myth of addiction. It's common to hear families talking about how they don't want their mom or dad or grandparent to have so much pain medication that they become addicted to it. Well, is the person dying, or are they just sick or recovering from an accident or from surgery? If they're actually dying, then maybe this worry about addiction isn't even necessary. In The Last Dance, on page 211, it says, pain experts point to a fundamental distinction between addiction, in which drug-seeking behavior occurs in an effort to reproduce that high, and physical dependence, which simply results in an abstinence syndrome after the patient stops taking the drug. If the patient's desire is to be as pain-free as possible when they die, then worries about addiction may become a moot point. That being said, it's easy for us to say that we would do this or we would do that, but how do we really know what we'd do unless we were faced with that situation? Considering your own life, what has been your worst experience with pain? How did you cope with it? If you developed a serious illness that brought excruciating pain, would you be willing to take high doses of pain medication, even though it would probably dull your thought processes? Or would you want to endure the pain? Why or why not? Now, just because that's the approach that you would prefer does not mean that others would choose the same route. And that's okay. It's their choice. Oftentimes, we want to medicate people because it makes us uncomfortable to see them in pain and suffering. But if they don't want pain medication and they want to experience that pain completely, that's entirely up to them. Pain was just one of the fears listed. What about the other common fears of the dying that we looked at? How can we help our patients with these as well? Here are some good starting points, some good suggestions. We can educate the patient as well as the family about the disease progression. What should they expect? What will happen? Does it occur quickly or over time? What comes next? Be sure we include the patient in the decision-making process. They want to feel some control over what's happening to them. Try to facilitate communication between the patient, family, and caregivers. If everyone's on the same page, they can be more supportive, and it makes things a lot easier on all involved. Involve the patient. Let them be a part of what's happening. They are still alive, so treat them that way. Encourage social support and engagement. Maybe they cannot go to their Friday morning coffee with friends or their Wednesday Bible study group or their Saturday afternoon bowling league, but can those people come visit them? Would the patient prefer that they called instead, or maybe sent cards? Ultimately, try to help your patient's needs and preferences be respected and upheld. Do what you can to help them live the fullest until they die, however they see fit. As we look at encouraging social support and engagement, we also need to remember these other aspects of dying. Their need to find meaning and purpose in life. Their need for hope and creativity. Their need to give and receive love. What this looks like and how it's done will be different for each person. Support them as they're trying to cope with these changes and impending losses. Be aware of any defense mechanisms they're using and help foster or encourage those coping skills that are positive and beneficial to the patient. The coping skills they're using may depend on how far into the illness they are, how recent the diagnosis was, and how much time they have remaining. We can develop our own skills and tools in working with the terminally ill. We can use education, communication skills, support groups, even counseling as ways to help them cope with what is happening. These may also be helpful for family or caregivers or even the healthcare team. Developing these skills places the crisis in a more affirmative context, making the experience less confusing, perhaps less melodramatic, and restoring a sense of personal control over one's life. We can encourage the dying person to engage in life review, which is a process of them looking back over their life, evaluating what went well, what was meaningful and brought joy to their life, what they might have done differently if they had the chance. It's an opportunity to reflect on the highs and lows, to see what lasting mark or impression they may have made. This can be very therapeutic and beneficial, not just for the patient, but also the family and even the larger family system or caregivers. As we're supporting our patient, we want to consider them within the context of their whole family. How are different people responding to the diagnosis, treatment, and dying process? Are there ways we can help facilitate communication or coping skills amongst and between family members? Finally, we want to be sure to accompany the patient to the end. It's great if we help them all along, but we don't want to abandon them at the very end because it gets hard for us, because that might be when they need us the most. We have to remember that the dying process evokes thoughts, feelings, and experiences in all aspects of one's life, physically, psychologically, socially, and spiritually. Pain and suffering can happen in any area of the whole being, and one area can accentuate the feeling in another. For example, emotional pain may increase the experience of physical pain, or vice versa. We have a separate lecture that looks more specifically at the process of dying in each regard, but there are a few other things we still need to consider here. The book we're reading, Final Gifts, is a perfect example of the spiritual dimension of dying. These things happen frequently, and we don't want to miss them. Some of these spiritual tasks include concern for a search for meaning, for establishing and maintaining a connectedness with oneself and other persons, and with what that person perceives as the transcendent, or the higher power if they have that belief. Oftentimes, when someone has a progressive illness, they develop a sense that death is coming. They may seem to have special knowledge about what is going to happen, or seem to have some sense of control over the dying process itself. This is what we call nearing death awareness, and it's very different from a near-death experience, which is something that happens suddenly and acutely as a type of out-of-body experience. We see that these near-death awareness experiences, which I've outlined in more detail in the next slide, really fall into two categories. One, they might be attempts to describe what someone is seeing or experiencing as they're dying. Or two, they might be requests for something that that person needs in order to die peacefully. So what might this type of experience look like or be like? Here are some examples. The dying person may see and hear things that others around them are not able to see or hear. Maybe they're talking to someone who died several years ago, or they seem to be having conversations with an invisible person. In essence, these people may be in between both worlds, the living and the dead, and it's as though they have one foot in each world. This is a common experience, so you want to let others know that this is normal. There's no need to medicate them or sedate them unless they're really agitated and distressed. Typically, these experiences are calming and enjoyable for the person experiencing them. They are not hallucinating or having delusions. They are simply having an experience that we are not a part of. We don't want to interrupt the person or try to reorient them to time and place. Instead, we want to allow this conversation or experience to take place. We can watch and listen, but the process does not involve us, and that's okay. It's their experience, not ours. At the same time, we have to remember that we have boundaries. Many patients are trying to figure things out or make peace with God or their life as they face their impending death. Our goal is to support our patient wherever they are, physically and spiritually. It's not to try to convince them, convert them, or try to push our own spiritual or religious beliefs upon them. At the bottom here are some points for us to consider. Remember, it's not our choice, it's our patient's. We cannot impose our views and values on them. It's normal for people to have conflicting beliefs during times of grief. Yes, they can be mad at God and still believe in God. They can turn away from God when they are scared or angry. These are normal human reactions, and it's not our place to tell people how they have to feel or what they should be doing about it. We shouldn't be barraging them with questions either, or judging them. What we can do, though, is help the patient and their family redefine how we look at hope. This has come up several times in class, and we'll look at it again now. We don't have to give up hope. We don't have to be unrealistic. We can focus on our interactions and their quality of life in the here and now. It's normal for hopes to be constantly changing. Maybe at first there's hope that a cure will be found. Then it's not, and people begin to hope for a happy, fulfilling end-of-life experience. Maybe they hope for pain management, or for family members to come together and reconcile any differences. Maybe they hope for little things that can change along the way. That's okay. We can help them find value in the loss and to recognize that even though the person is going to die, they can still have positive things that come from their life or come from this experience. We need to be honest with patients and still allow for optimism. When someone faces a life-threatening illness, they will likely handle it the way they've handled other stressors or crises in life. They will naturally revert to former coping mechanisms that work for them, and this is a very individualized experience. As stated in The Last Dance, quote, "The way we cope with dying will likely reflect the ways we've coped with living, the ways we've coped with other losses and changes in our lives." For many people, this is a family experience, and so we cannot solely consider our patient on their own, nor can we only consider their family without the patient. For many people, we do know that religion can help them make sense of their life, of their diagnosis, and of their death. Ultimately, we want to help our patient maintain their potency. In other words, we want to help them have the capacity to maintain a sense of self-worth, to set goals and strive to meet them, to exercise their choice out of an awareness of one's power to meet challenges, to engage in active interactions with one environment, and to sustain the will to live even in the face of death. Patients will often will themselves to live to a certain moment. Until then, we can help them live until their body dies. I have a beautiful example of this that I'd like to share with you. I have a friend, a woman I know that's a physician. She's from India, and she's lived in the U.S. for several years. As part of her cultural tradition, the father in the family shares the history of their family and traditions with the oldest son, who then passes it on to the next generation. She has no brothers, however. One day, her father called her from India and asked her if there was some time in the next couple of months that she might be able to come home and visit with him. She sensed, though, that something was going on. She had a feeling that he sensed he might be dying soon. She didn't say anything to him about it, but she arranged a flight home that next week. When she got there, her father was very pleased to see her. He sat down with her on the floor next to the fireplace and shared with her the family history, traditions, stories, and other important pieces of information. After he'd finished, he said he wanted to go upstairs to change clothes and get ready for bed. When he hadn't come back down after about 15 minutes, She called up to him. There was no answer. She went upstairs to his room, found him in his favorite tracksuit, lying on his bed. He was not breathing. He had died very peacefully, on his own terms, when he was ready. He did not commit suicide, but instead he had willed himself to stay alive long enough that he was able to complete this important end-of-life task. And then he had willed himself to die when he had that life work completed. It was a beautiful, peaceful death, and she felt so happy that she had listened to her instincts and gone home earlier than even he had requested. She was able to help him have his perfect death, and that was a wonderful gift that they had given each other. So I ask each of you to stop and consider the following questions. How do you want to live? And how do you want to die? How would you like to be remembered? Push pause and take some time to really think about these things. When you're finished, go ahead and push play to continue. Personally, here are some things that I would like to have happen as I die, if I'm so fortunate. I won't read each one out loud because you can read through the list. You'll notice that some of these things will benefit me directly. Others might help my husband and our daughters, or extended family. Some would help people feel as though they were able to do something that actually helped and made a difference. What are other ideas of things we can do for families? As mentioned in our lecture on the dying process, it's important that families know what is happening, changes that might occur, and specific ideas of things they can do to help or provide care at the end. We can teach them ways to reduce their anxiety, and we can provide ongoing support for their concerns, both practical everyday needs as well as bigger questions surrounding faith, God, or what happens after their loved one dies. We can provide families with information about other resources available in the community, be it support groups, counselors, family networks, or other social service programs that might be beneficial for them and or the patient. We want to include the family whenever possible, and up to those patients' wishes. If they want them very involved, try to do so. If the patient doesn't want the family involved, try to respect those wishes as well. We can also try to work around visitation hours and allow them to remain by the side of the patient if they are dying. Indeed, sometimes the only real hope you can offer a dying person is that you will accompany them to their death and respect their wishes to the best of your ability. In doing so, we also want to be aware of what we can do for ourselves and each other. Many of our patients become more than just a person we are providing physical cares for. We become emotionally invested and engaged with them and their families, and as a result, we are grieving their loss as well. We will experience a wide array of emotions, and that's okay. It's normal. We want to be able to support each other, to listen to one another, and to help each other. This is good work we do, but it can be hard work we do, and we're not in it alone. It's nice if the healthcare team can attend the funeral or memorial service, if they can send a card, and if the patient was under your care for a long time, to even consider acknowledging their death with some type of little ceremony or ritual at your place of work. We have to take care of ourselves if we're going to take care of others, and this includes allowing ourselves to grieve the loss of our patients while also taking on new ones.